Hi everybody, I am about to be joined by Dr. Kelly Beck from California Fertility Partners to discuss solo parenting tonight. So we're going to talk about everything to do with solo parenting process and expectations and different fertility treatment that you can have. So let's have her join now. Welcome to those who are joining. Good evening or good afternoon. Hello, how are you?
Hi, Eloise. Thank you so much for having me.
It's lovely to be speaking to you finally in person. I've been following and admiring your social media account for a long time because you share so much useful treatment content. So please could you introduce yourself and then we can start talking about today's topic.
Sure. So I'm Dr. Kelly Beck. I'm a double board certified reproductive endocrinologist at California Fertility Partners. And so, my goal here is always to empower all patients, whether or not, they're single or they're in relationships or not, or they're not ready to have children at this moment and they want to freeze for the future. But I think for me, the biggest highlight of this, which I'm really excited about to talk about, is not just to discuss having a child on your own, which is a very common choice among my patients, but also to think about planning for your entire fertility, for how many children do you want? Because I think the focus oftentimes when you're single is people just focus on having one child, and that's really not the goal for everyone. So thank you for having me.
Amazing. And that's such a good point because there are some people that I know and there's some people that I've worked with who have got to a stage where they've decided, right, I want to freeze my eggs now.
Right.
I'm not too sure what the future looks like in terms of family building. And so do you feel that it would be good for people to be better educated in terms of making these decisions a little bit earlier in their life if they're able to? Or do you think that it's something that takes time to realize that's what you might want?
I absolutely think it's a great idea just to get a sense of what your fertility is like for yourself. You can't look at a woman and say, oh, great, you're 30 years old, you have great fertility. Everyone has a different ovarian reserve, and especially based on what your fertility goals are. So if you want one child, our recommendations and our planning will be completely different than if you wanted a large family of five. And so it depends on your own personal history, how many children you want, when you want to start having them. And also, I think there's a lot of questions about support systems. And I think there's a huge network of support that people are they have no idea about, or people are embarrassed. But when they realize that this is very commonplace, we do it all the time. You don't necessarily need to do IVF if you just want one child and you're young. You're not infertile, you've never tried. And so this is something that I usually try to review. But whether it's for your first child or not, and you want to try to conceive on your own, I think a baseline is great, not only to assess your fertility, but also to kind of get an idea and make sure you're not wasting your time. Are my fallopian tubes open? And you can do that with a hysterosalpingogram.
Yeah.
Is my cavity normal? Is there a polyp? And you also want to know, are your hormone levels normal, like your thyroid? Are you immune to all the necessary things? So you don't waste your time trying. Because I know some women, if you're a single woman, and they start trying at home, they'll try sometimes with these different vaginal caps or cervical caps at home. But it's really devastating when it's not working and they find out later that it's because their tubes weren't open or because their hormone levels are off.
Mm-hmm. Everything you're saying just brings so many questions to mind. So, for example, and we'll probably talk a little bit about preservation in a second for people who aren't at the stage of necessarily trying to have a child. But for those who are doing it solo, and if we're thinking about women to start, do lots of women try and do it themselves at home? And what would they tend to do at home? And what is the accessibility to things like donor sperm?
So, I'm going to be honest, when they do this at home, oftentimes women will do it on their own, not using donor sperm from a sperm bank, but they sometimes enlist a friend. And so they will have, they'll monitor their ovulation and they will have their friend provide a sample. I mean, again, this is not with our office, but this is just on their own.
Yeah.
They'll get those cervical caps and they have those like Diva cups or the menstrual caps. They'll put the donor sperm, put it on the cervix when they're ovulating. And, basically they're not infertile, they're just trying to be exposed to sperm, so it's completely appropriate. But what you don't know when you're using your friend is, not every man has great sperm. You can see the ejaculate. So even if you're doing this, I advise For single women, even if you want to try at home on your own and you have a friend, you still should make sure their semen analysis is normal. You want to make sure they don't have any infections.
Mm-hmm.
And I also really advise you get a reproductive contract, because when you're not doing it in a fertility practice and they're not designated as a known sperm donor, there's always a question of custody if they change their mind and they want to come after the child. So again, this may be different in the US than it is in England, but I know in the United States there are certain, rights of the father, of the sperm provider, that you want to make sure that you have protected your custody rights.
I think that's amazing advice. And so when you see patients who come in who are pursuing solo parenthood, what stage are they normally at? And this is one of the questions that came through in advance. How would you say, okay, let's try IUI versus IVF, for example?
Okay, so that really depends. Again, when I first started is how old are they, how many children do they want, and what does their ovarian reserve look like? So if they said, a lot of my patients haven't started on their own and they haven't tried the Diva Cup or anything on their own, and they come in just to get an assessment. So when we do an assessment, if everything looks perfectly normal and they're young or they have great ovarian reserve, I will recommend that we just check a basic evaluation of their hormones to make sure their thyroid is normal, they're immune to chickenpox, rubella, and measles, and to make sure they do a basic hysterosalpingogram with the radiologist to make sure the cavity is normal and the tubes are open. And then I also check a CMV status, the cytomegalovirus, IgG, IgM, because if you're IgG positive, you can choose donor sperm that's positive or negative. But if you're negative, you really should choose only negative donor sperm because of that. That's kind of important. The other thing you would really want to make sure is to know if you're trying to do this and your hysterosalpingogram is normal, is to consider monitoring your natural cycle at least one time to make sure, hey, I'm going to do this in correlation with my menstrual diary. And when I think I'm ovulating, am I really ovulating? And if you are, great, we can just time your insemination based on that. But because timing is everything, especially when you're using donor sperm, and donor sperm's not free, what I do recommend is monitoring that natural cycle. It's not about simply that you're ovulating, but that you're ovulating at a good size and triggering ovulation and doing that insemination at the right time, which is the main reason we're open 7 days a week, because timing is everything, especially when you're doing an insemination. If it's fresh sperm, it'll live for like 2 to 3 days. But with donor sperm, really after it's washed, it only lives for 24 hours. So you really want to make sure you have that timing perfect. The other thing we also do is we check your hormone levels 1 week after ovulation, just to make sure, yes, you're young and healthy, but do you need any luteal support? Because the last thing you want to do is to not have given your body an opportunity to hold on to that pregnancy because your corpus luteum, the follicle where you ovulated from, is not making enough hormones to support that lining.
That's great advice, absolutely. Just going back a little bit to what you were saying about CMV, because I know that I was pursuing parenthood with my husband who's infertile, but similarly in terms of picking a donor, there are some similarities there. We had the conversation about whether we would be picking someone who was CMV negative or positive. It turns out I hadn't been exposed to the virus, so we went for someone negative. Because I've spoken about this with sperm banks before, how strongly do you believe that someone needs to worry about that?
I don't think there's enough data about this, because usually if someone's sexually exposed to them, we're not checking CMV status. So I don't think the data is really out there. However, if you speak with a high-risk OB specialist, they will tell you that there's a potential risk. And I think whenever, as a fertility specialist, if I'm here to mitigate all risk.
Yeah.
I want to make sure everything's perfect.
Yeah.
So
Absolutely.
that's why, if it's for me and my personal choice and I'm caring for a patient, I really will advise them against using a CMV positive if they're CMV negative. The other thing is, you want to make sure the genetic disorder screening of the sperm donor, have they had an extensive test? And if you are looking for specific disorders that maybe, you're positive for, you have to make sure that you speak with the genetic counselor to make sure the sperm donor has been tested and screened for that. And if they have, great, but is it enough? Do they have to do any additional testing? Because I think that's another part that we don't always think about, is the genetic disorder testing.
Yeah, absolutely. And what do you advise for patients? Does it completely depend on their situation in terms of how many vials they might need to buy, for example, whether they're planning for more children?
Absolutely. So sometimes it depends on how many children they want and if how old they are, and also if the sperm donor is active or not. Because if it's
Hmm.
active, you don't really have to stockpile and purchase a lot of it because it's, there is going to be additional vials available. If they are really, completely tied to this one sperm donor and he has a finite number of vials, then with some sperm banks, what you can do is you can purchase it, but don't transport them off-site, because some sperm banks will purchase it back at 50%, like at a certain lower percentage rate, but
Yeah,
they will purchase it back if you don't use it.
absolutely. Yeah. And then, so when someone comes to see you, you obviously look at all of their history and what they're after in terms of their family building to assess what kind of treatment you might suggest for them.
Right.
And what do success rates look like for people who are doing it on their own?
So because they're not infertile, because they've never tried on their own,
Hmm.
I think it's completely comparing apples to oranges, comparing an IUI for someone who's never tried versus an IUI with someone who's been trying for 6 months or a year. And so usually I quote the normal 15 to 20% per month, as long as everything is normal. Their workup is completely normal, they're ovulating properly. And you're getting the timing perfect, it's about 15 to 20% per month. If
Hmm.
it doesn't happen in the first 6 months, then that percentage drops, as it would in anyone who's trying, to less than 5%. But again, if you're older or you have a lower ovarian reserve, you don't want to waste too much time just trying it naturally, because you have that finite window and you certainly would hate to miss that window. So that's why I think getting an assessment even before you're ready to try is a little important, so you really know and you're not regretful that, oh gosh, I wish I'd moved up sooner than later. But I always like to advise people, you don't need to do IVF. Like, IVF isn't always the answer. You probably could conceive with an IUI. And so let's try with an IUI first.
Hmm. Yeah, I was hoping to have IUI because of my husband's infertility, but due to
Right.
location and going to the States, just in terms of timings and chances, we needed to bank embryos. But yeah, I mean, it sounds like a great option for someone who doesn't necessarily need all of that. And can people have lower dosages of IVF in their cycle as well if they don't necessarily need,
Right.
if
So
it, if it
it's
didn't seem to be.
really, when you're single and you're not infertile and you're doing this, and you're doing it purely because the lack of absence of exposure to sperm,
Mhm.
then what you oftentimes don't need a lot of medication, and so I don't believe, a lot of times my patients will ask for higher dosages, but what I remind them is every follicle has a finite number of receptors. So even if I give you a high dose, we're not being more aggressive, because people always feel like we're being more aggressive with higher dosages, and that's simply not the case.
Yeah.
What's more important is having the right dosages of medication, not over using high doses, because when you do high doses, really what ends up happening is once those receptors are filled, you waste it. You're just going to urinate them out, and those medications are not cheap. The other thing is you can make the membrane of the egg more fragile. So to me, what's really important is synchronizing your follicles to make sure they're similar in size, trying to avoid using birth control pills, because a lot of times people will synchronize using birth control pills because it's so easy. But the downside of birth control pills is it can suppress someone. And so someone who has completely healthy ovaries, you've now suppressed it. So now we have to use more medications or longer dosages of medications to stimulate. So we try to avoid that. And then again, timing of when you trigger ovulation is really key when you do IVF or an IUI. You want to make sure you don't overcook those eggs. So you go for the lead follicles.
Absolutely. And what about considerations for people doing it on their own, when they're actually going through the process? Anything to think about in terms of support?
Absolutely. So I think what's really important is, first of all, you have to decide, are you going to use a known sperm donor, like a family friend, or, just a good friend that you have? And how do you want to do it? Are you planning on co-parenting with this person, or is this person going to simply be providing you the sperm? So you have to have that very clearly defined. Or if you're going to use anonymous sperm. I think that's the first decision tree that you have to make. Which way are you going to go? Then you also want to know who else is out there for you. So a lot of my patients will work with an acupuncturist, because I find acupuncture on the right hand can really help with how you ovulate, and they also provide another level of support. So a lot of my patients, I feel, have this team around them. It's myself, they have the acupuncturist, and so and also my staff. So in our office, they see me for every ultrasound. There's no tech, there's no doctor of the day, and I think it makes a difference. But I
Massive.
also think that, when you normalize it and you make people realize this is really common, like this is something that a lot of people are doing, it removes a lot of the stigma and shame from it. And so I think that that also helps build the community around it because people are more open about talking about it.
Absolutely. And also working out who you want to tell things to, I guess, so that you've got
Right.
your support network of friends and family, like you said, so that whilst you're getting that medical attention, you've also got the emotional support as well. And
Right.
that's so important if it goes well and if it goes to plan and you end up with a baby as well for solo parenting, in terms of having support around you at that time too.
Yeah, absolutely. And I also, provide the recommendation of a psychologist, a reproductive psychologist for anyone who's going through fertility, whether doing it solo or not. And sometimes, especially if you're doing solo, it's nice to have that support to kind of discuss how will you talk about having, this child when you have your child, and how will you tell their birth story for the child. And I think that's important. And so it helps navigate those different questions and how they're going to feel before they become pregnant. The last thing you want is someone who hasn't had an opportunity to really vet all those questions before they become pregnant.
Definitely, definitely. Before we move on to men, could we just talk a little bit about people planning for children in the future? So obviously talking about egg freezing, for example. At what stage would you see people who might be coming in to freeze eggs thinking about future children? Is it at a later stage than you'd like them to come in, or do you think that people are coming in younger today?
In the beginning, I think, about 10 years ago, people were coming in when they were turning 40. But now, recently, in the last 5 years, I find that most of my patients are arriving probably in their late 20s or early 30s, which is great. But unfortunately, even for some of these younger women in their early 30s, what's surprising is when they realize some of them don't have a lot of follicles, and they're always a little stunned
Yeah.
that, oh my gosh, like I can't believe I don't have a lot of follicles. My girlfriend has, 30. How is it that I only have 5? But I always tell them, I may not give you the information you want, but now you're empowered to make those decisions about how do I want to do this. Maybe you're not the best candidate for egg freezing, but you can certainly conceive on your own, and your chance of conceiving on your own with a natural cycle IUI is just as good as anyone else your age. Or if they're not willing to change their timeline, I have to tell you, Eloise, everyone who walks in who wants to freeze their eggs, even if they're young, they're not always a candidate. And I will talk about conceiving earlier than they thought or creating embryos with donor sperm. It's not always a conversation they want to have, but I think it definitely makes them think, and they really make those decisions about how they want to proceed forward. But I do think that freezing your eggs is always just the potential. You have to remember you don't know how they're going to thaw, fertilize, and how they're going, if they're going to have result in genetically normal embryos. So with an embryo, we know it's much more reliable because it fertilized normally, it's genetically normal, and that one normal embryo based on your age, if you're 35, will give you a 70% live birth rate as long as there's no uterine factor. But again, I'm really open to helping women decide what they want. For some women, creating an embryo with donor sperm's not on the table. That's like not even an option, and that's okay. But then we really have to discuss how should we plan this.
I guess for some people who might be freezing their eggs in their 20s, let's say, and haven't met anyone yet, there's a conundrum, isn't there, that they may not want to freeze their eggs with donor sperm in case they meet someone in time.
Absolutely, especially when they're in their 20s, no one's thinking that they're not going to have a lot of follicles. But I'm going to be honest, 1 in 10 women have endometriosis, and when you see a really low ovarian reserve, even when someone is completely asymptomatic, I have found and diagnosed endometriosis very early in these young girls, young women who are like 25 or 28, and they have like 5 follicles, like totally just like 5. And so when they have that, and we send them to an endo specialist, we do preserve their fertility a little bit longer because now they know they have endometriosis, and they're making those lifestyle changes to address it and preserve their fertility a little bit longer. So I monitor them annually until they're ready to have their children.
So do you find that sometimes you have to break news like that to people where it's totally out of the blue and they're completely shell-shocked by it?
Absolutely. And, with every patient that I see, I always tell them I have a conversation in my office first and the reason is, people are really nervous when they get into an ultrasound room. Everyone, however calm they seem, they're really nervous about what are you going to find. And I think that having this conversation about all the things that we can have, all the potentials, what am I looking for, and then going into the ultrasound room and knowing that, hey, even if we have a lower number, these are the things we can do, perhaps with lifestyle. Are you sleeping well? You know, people don't realize how important sleep is. It's not just how many hours of sleep you get, but what time you go to bed, the quality of sleep. You know, and we think about our lifestyle. Are we smoking pot or cigarettes or vaping? You know, those can age our ovaries more quickly. And people don't realize that these things are not always necessarily benign for our eggs. And unfortunately for women, unlike men, who are always making new sperm every 2 to 3 months, for us, when we have these insults against our ovaries, it doesn't come back. And so I think just educating them, so even if they're not ready today, Eloise, I think what happens is they make lifestyle changes that they'll help preserve their fertility for when they are ready.
Mm-hmm.
And for some women, I don't tell them to freeze their eggs. I tell them, look, you're young, you just want to have one child, maybe in a couple of years. Let's monitor you every year until you're ready to have a child, because you don't always need to freeze your eggs.
Yeah, I think that's great advice. Excuse me. I was also very, I know, as I mentioned before, I was doing this with my husband, but because the infertility is on my husband's side,
Mm-hmm.
I assumed that IVF would work first time. And you probably have similar situations where you have women who think, well, this will work straight away because there doesn't seem to be a problem. I just don't have the sperm. And
Right.
so when we found out that the first cycle of IVF didn't work with the donor sperm, I started to second guess everything, Google like mad, self-diagnose, and start to think that there was a problem with me. Do you see that a lot in patients, that people start to spiral a bit if it doesn't work straight away?
Absolutely. And so I always, I always remind women, even if your live birth rate is 99%, nothing is 100%. So there's that 1%, and it's not you. It could be the embryo, how it continues to divide, if it doesn't implant. But prior to doing a transfer, after we have genetically normal embryos, I do talk about considering doing a mock cycle to make sure, did we check everything about on a microscopic level about your uterine lining for implantation, about the dosages. Is there anything that we need to worry about? And I think that when we've done the $1 million workup, I mean, it's not really $1 million, but when you've done the evaluation, it gives people peace of mind, like, okay, great, my body works. And now let's see what nature gives us, and if it's going to be healthy. Because the other thing you have to remember is, even if an embryo is genetically normal, the reason it's not 100% is it has to be structurally normal, continue to divide. You can't check for every disorder under the sun. And there's also anatomic issues, like if there's a heart defect or brain defect, that's not something we can assess for yet.
Mm-hmm. And do you find that patients need several rounds of treatment when they're doing it on their own, or does it just completely depend on the individual?
It really depends on the individual, what their ovarian reserve is and how old they are, because age is the number one predictor of live birth. And so if they're younger, even if they have a very low ovarian reserve, their chances are still just as good as everyone else their age. But if you're 40, it's a lot more challenging, because 90% of your eggs are not going to be genetically normal. So there is both there's a real egg factor. So you want to make sure that you address that appropriately.
Speaking of which, I was going to ask you, for someone who might be having IVF solo, would you tend to do PGT?
I do, and I'm going to tell you why. Because there's no correlation between how beautiful an embryo looks and if it's genetically normal. In our lab, we actually, after fertilization, we don't look again until day 5. I know some centers look at them daily, some will look on day 3, and then day 5. What we found is that by doing a continuous culture, we don't change the pH, temperature, or gas exchange, and embryos just do better.
Right.
And what you also want to do is, because we transfer one embryo at a time, if you don't know if they're genetically normal, every embryo is not going to be normal. So even from an egg donor, if I have 15 blastocysts, typically, maybe 3 or 4 will be normal, but there's going to be 9 that aren't. And it's not always embryo 1, 2, 3, 4 that are normal. Mm-hmm. So you avoid going through failed transfers, you avoid miscarriages. So that's really why I recommend considering doing genetic testing for the higher live birth rate. But the other thing is, you're paying for storage of these embryos. Do you want to pay for storage of embryos that aren't even normal and not going to result in live birth?
Such a good point. Do you, because I didn't have my embryos tested 5 years ago, do you feel like that's changed over the last 5 years, or has this always been?
Absolutely. So I did IVF myself, and I have twins from IVF. And back then, genetic testing really wasn't an option, because we could only test for 3 chromosomes at a time. So what's the point of that? And we weren't doing blastocyst testing. It was day 3 testing. And, day 3, there's only like 4 to 8 cells. So you're removing about 12% of that embryo. Whereas now with day 5 testing, you're taking out less than 1% of that embryo. And of course, embryos are going to survive better, but we're also very cognizant of what we biopsy. So we don't just biopsy anything that looks like a blastocyst. It has to be a structurally normal expanded blastocyst so they survive well. Because I know there's this misunderstanding in the community that, oh my gosh, you're going to harm that embryo. I think if you go to a center where they do this all the time, over 95% of my patients do PGT. No one wants to do a fresh transfer, even if they're young. I think because the technology is available and it doesn't harm the embryo.
Absolutely. You've got an amazing lab at California Fertility Partners, haven't you? I mean, I haven't seen it in person yet, but I've seen pictures and heard that it's just state of the
Oh,
art.
thanks. No, it is state of the art, but we really take a lot of pride in it because we know, we're here, patients come from all over, but it's not because patients come from all over the world for us. It's really because we realize what a huge toll it takes on your emotions, financially, that when you do IVF. So we wanted to make sure that we've optimized everything possible. That's also why we work 7 days a week. So there's never a question about timing. But in our lab, we're really fortunate. We've really focused on investing in our lab where we have a cleaner lab. We're always working on what can we do and change and add new technology. But we also have all senior embryologists. Not every lab has all senior embryologists. Most labs have 1 or 2 seniors and the rest are juniors. But for us, we want everyone to be a senior because we want to make sure that everyone is giving its best and there's never a question that, oh, it was on this day when there wasn't a lot of senior embryologists available.
Absolutely. Gosh, I'm learning so much from you. Thank you. Does anyone who's watching have any questions for Dr. Beck? Please ask now. One thing we haven't touched on, which is men doing it solo. What's the process like there? Obviously, it's I presume more complicated.
So it's a lot more costly for men. It's much more costly for men. So it's an egg donor, and they also need a surrogate. So even for men, they also have to check their sperm. And we also go through their own, like, how can they optimize it? Because 50% of the DNA is sperm, 50% is egg. And what's interesting is when men come in, no man ever walks in with the assumption that potentially there could be an issue with their sperm. So we really make sure, is the sperm okay, yes or no? Then we go through the process of an egg donor. Do they have a friend who wants to provide an egg donor, like their eggs, or are we going to use an anonymous egg donor process? So I connect them with a psychologist because I think whenever you're using donor gametes, it's really important to make sure you vet that out. We do the genetic testing on the men to make sure they're not a carrier for any disorders. We have to make sure that donor doesn't carry. I go through, like, what are you looking for in your egg donor? Like, what are attributes that are really important to you? And I had to remind them, like, I look at it from a medical point of view to make sure they're healthy, they don't have family history of cancer or psychiatric issues at a younger age. And we want to make sure that we vet the donors well. And then we talk about surrogacy. Surrogacy is, quite costly. It's when you have someone else carry the pregnancy. And with that, sometimes I always ask, do you have any family members or friends who could potentially carry for you? Because that's really the most costly part. And so if you can have someone carry the pregnancy, but if not, we want to make sure we choose a surrogate who, they don't have to be a repeat surrogate, but are they healthy? They have a proven uterus? Do they have any obstetric complications? And we send them to a reproductive attorney to make sure that all the necessary contracts are in place. Because in the United States, not every state is surrogacy friendly. So they have these different nuances. And if they're coming internationally, we want to make sure there's no issue taking your child back home.
So I presume the process for a man is longer, more expensive, but also longer in terms of waiting for the surrogate and the selecting the egg donor maybe than donor sperm.
So oftentimes with the donor sperm, when it's a single male who's finding an egg donor and a surrogate, because we're looking for a healthy surrogate, we usually do the process in parallel. And oftentimes when it's a man looking for an egg donor, it's very different than when I have a female patient who's been trying for a really long time, then looking for an egg donor. It usually takes a bit longer. But men, usually they're not tied to, there's no weird implication about finding an egg donor. They have their criteria, they find their egg donor, so it's pretty quick. So once an egg donor walks in the door and they've chosen their egg donor and they're medically screened and legally screened, then we can usually have their eggs out within 6 to 8 weeks after coming to the office. During that time, in parallel, we will screen the surrogate. And I usually do a mock cycle on my surrogates, even if they're a repeat surrogate, because our bodies can change. You want to make sure that implantation window didn't change, because even when you're using an egg donor surrogate and the live birth rate is 80%, I try my best not to leave anything to chance. If there's anything that we could potentially miss, you want to make sure you've checked everything. And so even if it takes takes a little bit longer, it's so much better to make sure you've checked everything under the sun.
Yeah, absolutely. And that's something, sorry, I'm just thinking that we didn't
No.
really touch on before in terms of selection process of a donor, whether that's egg or sperm. Slightly different for people doing it on their own, isn't it? Because they're not necessarily trying to match, they may not be necessarily trying to match a partner's genetics.
Exactly.
Exactly. Trying to match a partner who can't have a child.
Right. So
That
I
might
think
open a
why
bigger
it's a little
pool.
bit quicker. I find that oftentimes for my single male patients, they find a donor pretty quickly because they don't have any hiccups about it. There's like no emotional like roller coaster that they go through when they look through these egg donors.
Yeah, makes sense. Makes sense. And what percentage would you say are solo mothers by choice versus fathers?
For my patient population, it's different because there's 4 physicians in this practice, and Dr. Ringler, who I know you've done an Instagram live with, has a lot more solo male patients.
Yeah.
But for myself, I have a lot more solo female patients. But I would say for mine, between solo male and female, it's probably 80% female, 20% male.
Yeah. Okay. Interesting. This is a bit off topic, but before we go, someone's just asked, is there anything you can do in the 2-week wait to help the odds of implantation?
So for me, with the 2-week wait, laying in bed, that's not going to do anything. So I really find that if you have an acupuncturist or you have your support network, that can be really helpful, because a lot of times during that 2-week week, everyone is like feeling themselves. Do I feel any symptoms? Are my breasts tender? Like, what am I feeling? So I always just say, you kind of just have to live your life, because the more you focus on it, it can be really stressful. So if you have your network, this is the time that you see your friends. And so you want to make sure that you're out there and like kind of hanging out. You're not solo thinking about it on your couch all day, because I think that can be really stressful.
And just thinking about support, just quickly to end on, for people who are doing it solo, who do they normally bring to procedures and things like that in normal times when you're allowed to bring people to procedures?
So we recently started, the last month, we've allowed people to bring their support person. And so a lot of my solo patients will bring either a parent or their best friend to the room. And so I think it's always nice for them, whether it's for the transfer, it gives them a little support. But some patients actually will want their acupuncturist with them rather than a family member or friend.
Really?
Yeah, because not everyone tells their family members or friends, but it's interesting because there's always stigmas of certain cultures. But I think that for the patients who don't have any and their family knows about it, it's really wonderful seeing how people really rally around my patients.
Definitely. My husband couldn't be at any of my appointments, not because of COVID, but because he was recovering from microtesticles surgery and because of that and work on a couple of the other transfers. And my father-in-law stepped in and came, and we made jokes about what people thought in the waiting room, looking at him as a silver fox with me wondering what was going on here. But yeah, it's obviously important, isn't it, to work out who's going to be supporting you through that, and therefore the procedure to pick you up after egg collection, etc.
Yeah, no, but it's interesting how it's interesting that you said it was your father-in-law, because I have had some patients when they bring a parent, everyone assumes it's the mother, but it's not. I've had a lot of patients bring their fathers, and so I think there's like a different support system, and they just don't have to worry at all, because it's interesting. But you're right, you just have to figure out who's your person, who's your go-to person that if you have to talk to someone in the middle of the night, this is the person that they can call.
Oh, someone said, have you read that someone said that you're one of the best REs in
the Oh, that's so nice.
Do you have time for 2 very quick questions?
Of course.
What about endometrial scratching for implantation?
Okay, so endometrial scratching is not something that's well vetted. It's something that I worry about. When you do that, it can actually cause scarring in the uterine lining. I've had some patients where they've had endometrial scratching and then they've had failed transfers. And when we do an assessment, we realize they have Asherman's. And so Asherman's is when you have scarring inside your uterus. So in someone who had a pristine uterus, they now have created a uterine factor. And so then we have to go through surgery, and I send them to an Asherman specialist. So that's something I really don't recommend. I don't think it's well vetted. I know it's out there, but it's not something that's universally accepted, so I don't recommend that. I do think that if you're looking for a uterine assessment, please consider the endometrial function test, where you send it off to Yale. If you're looking for endometriosis, the Receptiva, where it's specifically for endometriosis, or the ERA, and someone who's had secondary infertility, that we know that they can carry a pregnancy, but we want to make sure we have the correct window.
Absolutely. And what about intralipids?
Intralipids, that's very controversial.
Yeah.
I actually, our society doesn't support it. The American Society of Reproductive Medicine, I don't support it. So I know that there's a lot of reproductive medicine immunologists who will consider doing it, but that's something that I will not do. And so if someone wants to do it, I support them, but I will send them to the reproductive immunologist to do that.
Got it.
I don't think there's a lot of data for that. I think there's sometimes when we do certain things that's not well vetted or well supported, we can do harm. For example, can I just add one thing? So
Yeah.
some patients will ask about blood thinners. Well, what you have to remember is if you don't have a blood clotting problem, you can cause a miscarriage because you're going to cause bleeding in pregnancy. And so whenever patients ask me, like, oh, what about, can I consider aspirin or Lovenox? Because I read it online, like, no, you don't have a blood clotting problem. And the blood flow between the uterus and placenta doesn't happen after 14 weeks. So if you're having early losses, it's really not likely the cause. Of course, we can send you to a hematologist and have that checked out. But you have to make sure, even if you are positive for any of the blood clotting disorders, make sure it's something that's clinically relevant in pregnancy. Because using aspirin or Lovenox when it's not indicated can actually cause more harm than any benefit.
That's really interesting. Thank you. Someone just asked about clinics in the UK. Are you seeing people from overseas at the moment, or is it too difficult?
I am. So I'm actually seeing a lot from the UK.
Okay.
But they're quarantining for 2 weeks.
Okay, so they're allowed to come over.
So they're quarantining for 2 weeks. I had one who just quarantined for 2 weeks in the Bahamas. But yes, they are coming over. They're also getting medical visas. I've had some patients from the UK go to Switzerland and then through, or from the UK to Greece or to Turkey and then come through.
So it can be done.
No, it can be done.
A bit of planning. Absolutely. Thank you so much, Dr. Beck, for everything.
No, thank you so much for having me.
So much. I'm sure everyone's benefited as well, and it's been lovely to chat to you in person today.
Great. Thank you very much.
Thank you for everyone joining. Bye, everyone. Bye.
Bye, everyone.
Bye.